Yes, thank you for that. Sorry, I didn't pause on that. And good afternoon, folks. We're looking for the arrival of continued Behavioral Health Advisory Board members to bring us into quorum, not yet having reached that yet. We think it wise at 10 minutes after just to go ahead and get ourselves going. We have lots of things to talk about and people here. And so let's go ahead and launch into our meeting for today. And we want to pause and make sure that we do some directions on interpretations with Ricardo.
Good afternoon, everybody. My name is Ricardo Garcia. I'm along with Gladys Ramos. We're going to be the interpreters for today's meeting. The instructions to access the interpreter via Zoom or your computer. After the host activates language interpretation mode, click the interpretation icon and select the language that you would like to hear. English and Spanish interpretation is available. Optional. To only hear the interpreted language, click mute original audio. Via phone or tablet, and your media controls, tap more at the bottom right in the mobile phone app and top right in the tablet app. After the host activates language interpretation mode, select language interpretation and click the language that you would like to hear. If the icon is not visible, tap the screen to make it appear. Reminder, speak slowly, pause between sentences, speak clearly, avoid interrupting or multiple people speaking, avoid using metaphor, acronyms, slang, or idioms. Interpret signals during the meeting, speak slower, raise your voice, interrupt for clarification or communicate a concern. Acceso al intérprete a través de Zoom por computadora. Después de que el anfitrión active el modo de interpretación del lenguaje, haga clic en el símbolo de interpretación y seleccione el idioma que desea escuchar. La interpretación en inglés y en español están disponibles. Opcional. Para solo escuchar el idioma interpretado, haga clic en omitir audio original. A través de teléfono o tableta, en los controles de la reunión oprima la opción más después de que el anfitrión active el modo de interpretación del lenguaje. Esa opción estará localizada en la parte inferior a la derecha de la aplicación en su teléfono y la parte superior a la derecha en su tableta. Una vez ahí, seleccione interpretación del lenguaje y elige el idioma que desea escuchar. Si el símbolo no está visible, toque la pantalla para que aparezca. Recordatorio, hable despacio, pausa entre oraciones, hable con claridad, evite interrumpir o hablar varias personas entre sí, evite usar metáforas, siglas, doble sentido o modismo. Señales del intérprete durante la junta, hable despacio, alce la voz, interrumpir para clarificación o para comunicar algún problema. Muchas gracias. Thank you so much.
Thank you. And as we now begin our introductions, I would like to just take a brief moment to look towards our membership and see the number of positions we have filled. Vice Chair John Stencil and I were just discussing prior to the meeting about the number of members present here today. And so we wanted just to check. Looks like we're having now 10 arrive. Okay, so we are at 10 members, so we can call a quorum. Give yourselves a round of applause. Outstanding then. Okay, well, let's go ahead then and begin, and we'll move around the table with some introductions. And good afternoon. My name is Chris Ridge, and I am the education representative and chairperson this year for the BHAB. And also just please make sure to touch your button and speak up into the microphone as you introduce yourself.
Hello, my name is John Stencil, and I represent District 1, and I am the first vice chair.
Rebecca Gregorian, District 4, Secretary.
Andre Popro, District 1, I believe still second vice chair.
Nancy Borchard, District 3.
Chris Dyer, law enforcement representative, Ventura County Sheriff's Office.
Sylvia Garcia, District 3.
Dahlia Robkin, District 4.
Soledad Barragan, District 5.
Okay, thank you for that. Then we can do our roll call of members too. We'll turn to Rebecca Gregorian.
Andre Bobrow,
Yes.
Cheryl Heitman, Chris Dyer, Dahlia Robkin,
Here.
Danielle Bednar, Diane McKay,
Present.
Frank Shilo, Genevieve Flores Haro, John Stencil,
Yes.
Marlon Torres, Michael Rodriguez, Nancy Borchard, Naomi Marufo, Natalie Torres, Rebecca Gregorian present, Soledad Barragan, Matt Lavere, Sylvia Garcia.
Present.
Oh, my apologies. He is present on Zoom. Sylvia, I heard you. Thank you. Chris Ridge.
Present.
Thank you, everyone.
Okay, and that's roll call of our members. Next item we'll turn to is the agenda. Oh, sorry, want to make sure we just point to one thing here, which is any board members who are participating virtually to state your name and if others are present in the room that are over the age of 18. Anyone present virtually? I think I see one at least. Supervisor Lavere, is your microphone working? Okay. Well, we see Supervisor Matt Lavere is present virtually with us here today. And we're waving at him and hopefully everything is working on the IT end.
Just
Any
got my
others?
audio. Yes, I'm here. Thank you, Chair.
There we go. Very good. Thank you. Okay. Any others? Just participate.
Yeah.
Okay. Okay. Thank you. All right. So next order of business on our agenda is the approval of today's agenda. So that's been posted and we'll ask for a motion to approve.
I move approval of the agenda.
Second.
We have a motion and a second. Let's go ahead and do roll call, please, Rebecca.
Andre Bubro,
Yes.
Chris Dyer.
Yes.
Just to confirm, I don't go through all the names, just the folks who confirmed they're here. Thank you. Dahlia Robkin,
Yes.
Diane McKay,
Yes.
John Stencil,
Yes.
Nancy Borchard, myself, yes. Soledad Barragan,
Yes.
Supervisor Matt Lavere,
Yes.
thank you. Sylvia Garcia,
Yes.
Chris Ridge,
Yes.
thank you.
And thank you. Next up is the approval of the minutes from June 15th, 2026. I think there may be a typo there. So June 15th, 2026 minutes, and those are included within your packet here today. Having reviewed them previously, looking to see if we may have a motion for approval.
Approval of the minutes.
Okay. Okay. Motion by Diane McKay, seconded by Nancy Borchard. Roll call, please.
Andre Bubro,
Yes.
Chris Dyer,
Yes.
Dahlia Robkin,
Yes.
Diane McKay,
Yes.
John Stencil,
Yes.
Nancy Borchard, Rebecca Gregorian, yes. Soledad Barragan,
Yes.
Supervisor Matt Lavere,
Yes.
Sylvia Garcia,
Yes.
Chris Ridge.
Yes. Next on our agenda is public comments. Might we have any public comments today? Looking in the room as well as, of course, online. Courtney LaBelle.
Good afternoon. My name is Courtney Lubell. I'm the Behavioral Health Services Act Manager. It's good to see you again. I just want to give a brief announcement that September is both Suicide Prevention Awareness Month as well as Safety Awareness Month. And the LOSAN managing agency of the Pacific Surfliner is launching a partnership with California Operation Lifesaver, a rail safety campaign that will be launched in September to communicate rail safety messaging throughout the entire rail corridor, including Ventura County, through online streaming services and geofenced mobile devices. One of the things to keep in mind is that California, not a good statistic to be on this one, is still ranked number 1 in terms of trespass fatalities, even above Texas. So this is something that the railway system is working on. We're also working to launch a collaborative with public health and the Railway Safety LOSAN group and our group, as informed by medical examiner data, to inform short-term, medium-term, and long-term interventions as it relates to suicide prevention and accidental deaths by railway. So I just wanted to pass that message on and have us note that for the month of September in particular. Thank you.
Thank you. And might we have any further public comments? Okay, seeing none, then we'll move on within our agenda. Next up is chair announcements. That would be from myself. And I have a few today that I prepared for you. First one of which, I'm honored to be able to serve as your chair this year within this role. Thank you. And I thought I would begin by just reading off for folks here present as well as online to hear about what it is that is the charge of the local behavioral health board as it's established in California law. It says review and comment on the county's performance outcome data and communicate its findings to the California Behavioral Health Planning Council. With that in mind, I have some performance metrics that I want to read off to you here. And these come from a recent report on behavioral health transformation. They are in reference to the 24-25 school year. And just want to bring some of these briefly to your attention here. And if others are asking or looking for more information, I have a pretty robust report here that I'm happy to share with anyone, but I'll just give you a high level of where it is that here within Ventura County, we're faring on some of the measures as they're outlined within what they call BHT or Behavioral Health Transformation Performance Summary. So faring above average, above the California average on follow-ups within 7 days after high-intensity substance use disorder treatment. That's our performance for that 24-25 year here locally, as well as slightly above the average in California's average, I should say, for follow-up within 7 days after psychiatric hospitalization. And next metric to point to is relative to the rate per 1,000 of Medi-Cal members with significant behavioral health needs who are experiencing homelessness. We're doing better than the overall average within California within that particular metric. And another metric to point to, that this one out of the metrics I'm bringing to you today is one for us to keep our eye upon. There always is within any number of metrics, areas of strength and areas where we can look for opportunities of growth. And this one is in relation to the percentage of folks being served that indicated the staff were sensitive to cultural background. And that's slightly lower than what the statewide average is. On another metric, where we fared here locally significantly higher than the statewide average, was within the domain of percentage of children screened with a standardized tool for mental health services. And so, again, overall, there are a lot of metrics reported, and I could share that report with you. I want to just bring you some high levels on that, touch upon a few that caught my attention, and make sure that that you're aware of that information. And should you wish to have any more of that, if you're not accessing it through the channels that came to me from our California Association of Local Behavioral Health Boards and Commissions, I'm happy to share that with anybody within the board, should you ask. So that information for you today. I wanted to give you just a couple other updates too. Legislatively, there's a couple bills that we want to have our eyes on. One is AB 2093, which is entitled Strengthening California's 988 Crisis Response System, which if you look at this legislation, it would streamline the process of communication between the 911 and the 988 system. And there's some room for growth within that domain. And so again, AB 2093, probably worth a look and perhaps consideration for advocacy. Another bill for us to keep our eye on is AB 2011, which is entitled Protecting Access to Mental Health and Substance Use Disorder Care. This one looks to address the issue of parity and making sure that we have access to mental health and substance use treatment at commensurate rates as other healthcare. And so I have information if you'd like. I have a fact sheet on that, as well as the AB 2093. If anybody would like follow-up information, I'm just referencing those for you quickly. Call outs on some advocacy recently, where it is that a number of organizations, including the California County Behavioral Health Directors Association, as well as the California Association of Local Behavioral Health Boards and Commissions, has been successful in getting funding reinstated. A letter was dated April the 27th of this year, going to our California legislature, and we're in fact successful in reinstating some funding that would have been slated to eliminate funding for mobile crisis benefit. And so that is something for us to feel good about our advocacy. And another piece of legislation, or not legislation, advocacy, I should say, was with support from the California Association of Local Behavioral Health Boards and Commissions, as well as locally here, a couple organizations in Ventura County, United Parents and MyCop, advocating for continued funding for innovative practices within the California Behavioral Health Advisory Board. And so all of those efforts had been successful on advocacy, and just wanted to call those out, that advocacy works. And the last thing I'll reference, I don't have a flyer on it here today, but colleague sitting next to me, John Stencil, was kind enough to invite me out to an event this last weekend, where I got to see an organization called MTC Surf, More Than Conquerors. And I got to see 18 youth who were engaged in surfing, many of them for the first time. And some of them, not some of them, all of them coming from backgrounds where they're either involved in foster care, kinship care, or perhaps had been trafficked. And adopted. So all of those domains with those kids all the way from ages 2 up through adulthood were out there learning to surf. And I was just so impressed with that. And John taught me a lot about how it is that really is so much helpful for the folks that have participated within the program. And so that'll wrap up my lengthy comments today. As an educator, I wanted to start off the year with a big bang. So I gave you a lot. So thank you. Those are my comments for today. And the last one I'm saving for last, which is it's a congratulations. It's one of those bittersweet congratulations, as we have learned recently that Dr. Dennering will be leaving VCBH, moving on into what looks to be a great place for you to serve within California, continued in your efforts. And in honor of your great work having been done here at VCBH, and thanking you, and also telling you we're going to miss you. We have a wonderful cake over there. I think it's lemon and raspberry. So we'll cut that in just a little bit. And so stay tuned and stick around, because we have a yummy cake. So, okay. And I think it's my job to conclude those lengthy comments and go ahead and turn it over to Dr. Dennering.
Well, thank you so much, Chair. It's been an absolute pleasure. I'll say more after we get done with budget during Director's Report. So we'll jump right into our budget for this current fiscal year that we've been talking about, that has finally been approved by our Board of Supervisors. And so folks have opportunity to ask questions. Today's presentation covers VCBH's accomplishments, our 26-27 budget, now approved budget some key financial risks, with some of which have been referenced by our chair in remarks, and some performance measures. So next slide. Or we're getting like this. Okay. All right, so this is a very busy slide because it's been a very busy year. So this slide tells the story of the department basically doing more with some very real constraints. As you can see, we have served just about 20,000 clients across our continuum this fiscal year. And that includes the implementation, not just serving clients in our day-to-day activities, but also implementing 90, that's 90 new mandated behavioral health reform initiatives over the past 2 years. Obviously, we've done a lot of work in our infrastructure area. So that includes our $100 million investments through the Behavioral Health Continuum Infrastructure Program and Prop 1. So our $59 million 38-bed mental health rehabilitation center in Camarillo, the about $5 million 16-bed psychiatric health facility in Camarillo, or I'm sorry, in Simi Valley, which will be located next to the future crisis stabilization unit, and also our $6.4 million youth-centered community mental health clinic in South Oxnard. As you can see, we have had done a lot of efforts related to suicide prevention, as was referenced earlier by our Behavioral Health Services Act manager, and we continue to work with public health on that transition under Proposition 1 as suicide prevention work transitions at the state level to the California Department of Public Health. At the bottom, you see reference to our staffing positions. This was as of March, when we were right in the middle of a countywide hiring freeze. So thankfully, these numbers are very different now that we've been allowed to recruit and hire for our positions. So our overall rate is low, our fill rate is higher than what you see on this slide, but this is from March. Okay, it's not going. Oh, did it go? Okay. I might have gone too many. That's really slow. Okay, it's just taking its time. I got it. All right, so some of you have seen this presentation, and this was what I gave it to the Board of Supervisors, and we've shown this over the years as far as the breakdown. Our revenue depends heavily on state and federal funding, with the Mental Health Services Act / Behavioral Health Services Act and Medi-Cal accounting for about 72% of revenue, which presents both opportunity and vulnerability, obviously. Our expenditures for this current year will be at about $412 million to support a broad range of services within behavioral health. So that includes our clinical services, our early engagement, residential, administration, quality assurance, and capital and facilities related expenses. Other funding also includes realignment and our opioid and tobacco settlement funds. Come on. All right. As referenced, our budget is composed of those majority of those sources, and CalAIM, which we launched just about 5 years ago at this point, significantly shifted how our payment and reimbursement system occurs at the state level, and also how we reimburse our providers at the local level. So as part of that CalAIM initiative, we had behavioral health payment reform, which shift us from cost reimburse to more of a fee-for-service model as we continue to make our way through capitation, like the other managed care models in California. So we are still assessing the anticipated Medi-Cal increases as a result of some of the shifts with payment reform. But we are, again, preparing the network for eventual capitation and shifting completely from cost reimburse to fee for service. So that is something that we like to reiterate because as part of BHSA and Prop 1, outcomes and transparency are key tenets of Proposition 1. And so one of the big pieces we as the department will be working towards on the fiscal side is what we're calling the BOTR, which is the Behavioral Health Outcomes Accountability and Transparency Report. That will be the first iteration of the BOTR will be due in early 2029. And so that includes all of our spending, all of our service utilization, and goals and outcomes that were included on our integrated plan, which was approved by DHCS in June of this year. This is very different than in previous years. The MHSA was very specific to mental health services dollars, whereas BHSA, we're reporting out on all funding streams. So again, not just Behavioral Health Service Act funds, but all of the funds you see here and any other dollars that touch the behavioral health system. Yes, Diane.
So it used to be, now they're paid based upon, I missed the compare how it used to be worded and how it is now.
Yeah, so as far as reimbursements in general, prior to CalAIM payment reform, so we're going back a little, 5 years, our providers were paid on a cost reimbursement. So you give us your budget, you give us your costs, and we would reimburse you on allowable expenses. Under payment reform, we've moved to a fee-for-service model, which is more common in the medical system, as the state is moving behavioral health into an eventual capitation model, like on the managed care side, where you have a per member per month, and you have to live within your means. You have to calculate and forecast based on projections of utilization. And you'll have some high utilizers, you'll have low utilizers, and you'll have to figure out how to manage with this set dollar amount per month. That is where the state is moving with behavioral health, and us as behavioral health plans will be moving in that direction with our network providers. That we won't have a choice. That's just how it will be. And so moving to fees for service is the first step. And the data collection that will come from the BOTR, from some of the other things I'll reference in the director's report, are what the state is going to use to develop those capitated rates moving forward.
Okay, that's always how I've understood it. So it's just like we always say, we don't know what kind of blueberries we're going to get. And so if we have someone who needs extensive services, is they're going to get the same fee as someone who maybe needed a little less mild treatment, but is still categorized the same way?
So on the service provider side, you're going to get a pot of money every month based on how many people you serve. And you're going to have to figure out how to pay your bills and provide those services with that limited dollar amount. It will just forever. It will be, this is your set per member per month, and based on times however many patients you have, and you will have to figure out how to provide those services within those constraints. And it's exactly how it works on the managed care side. Any other questions from?
So capitation, will that be a global capitation just for outpatient or including hospital and residential?
Great question. TBD from DHCS on exactly what will go into that rate. And we'll cover some of that in the director's report based on some of the new activities that counties will be doing as a result of Prop 1.
Oh,
Okay, that's so slow. Yes. Yeah, so as I said, that was from, this presentation was
different.
put together in March.
Yes.
For the presentation that was given to the board in May. That was when we were in the middle of a hiring freeze. The hiring freeze has since lifted, so we are filling those positions now.
Good.
Okay, this is just a very high level summary of our income statement. Again, about 35% of our increase in total expenditures for this fiscal year is largely driven by our capital investment. So obviously getting all of these levels of care online. Other financing uses include shifting our unspent Mental Health Services Act dollars into the new Act Services dollars division, and some other just cleanup and transfers. Okay. This slide is one we've shown to this board in previous years as we've started talking about the shift from MHSA to BHSA, and you see just how drastic the buckets have become with core services, what we used to call core services, basically being reduced by almost $20 million. And for core services, that is the funding that supports clinical treatment, crisis, recovery for our highest need individuals and carries the most operational risk. As I've said many times to this presentation and to others, this BHSA transition is not just a funding restructuring. It fundamentally reorients priorities towards full service partnerships. So that's the FSPs and housing at the direct expense of core treatment services. Again, when this was all conceptualized several years ago, Medi-Cal was in its state that at that point wasn't, not necessarily touched and was being encouraged to maximize and leverage, which we have done and continue to do. Obviously, and we'll talk about this in the next slide, with some of the federal changes, there is some unknown in that area as far as what will happen with the Medicaid portion. And the design of BHSA is to build off of Medi-Cal. So it is, again, and the same way MHSA was considered the funding of last resort, and you want to maximize and fully utilize Medi-Cal. The same is very much for BHSA, but there are services that Medi-Cal does not cover, and that's where your BHSA kicks in. And in previous years, we had a lot of flexibility on where we could shift funds and move funds, and now under BHSA, it is very, very compartmentalized. And so you can see, again, these shifts, FSPs and housing and housing for chronically homeless, see major gains, which obviously reflect the state's clear policy direction towards intensive wraparound and housing models. And then, as I referenced, prevention, intervention, innovations, and wet force education and treatment funding is eliminated under BHSA and shifts to what is considered kind of the catch-all allocation, which is behavioral health services behavioral health services allocation, which is like your general catch-all. And so we would have an opportunity, should there be funds there, to fund some of these other areas. But that, again, bucket, the BHSS category, is very, very constrained, given that the majority of the dollars have to go towards FSP and housing. Again, when you're talking about Medi-Cal and some of the threats there with some of the federal changes, there will be an impact on a reduction in Medicaid dollars. As you saw on the first slide, about a third, or about $100 million of our funding is from Medi-Cal, which is Medicaid. And we estimate, based on some of the changes related to the reduction in the federal medical assistance percentage, which is FMAP, we do anticipate seeing about an $18 million kind of reduction based on the percentages that we can claim to Medi-Cal. That will become effective of next year, October, these changes take effect. So this will directly increase the county's share of those services, whereas we used to have a higher match from the federal government, we will have a lower match. And there is no offsetting revenue for that. So the county will have to provide more dollars to match those services. And again, we want to increase services. We want to make sure that we're fully utilizing services. But every time we increase Medi-Cal services, you also increase your match responsibility. So you have to pay a portion of what the federal government doesn't cover. So each time you continue to maximize, you also have to have a match to go along with it. BHSA is typically our match for that, but given the reconfiguration, that pot of money that we would use to match has shrunk. So you see where there's some conflict there, because yes, we want to continue expanding services. We want to continue to provide more Medi-Cal services, and then you have to have more of a match to provide those. And so that BHSS category, that one little slice that's left, is also the category that will be used to serve as the match for those clinical services. Oh, let me go back. Also, right before, we'll talk about this a little later, but oh gosh, this thing is like got a mind of its own. Go forward, sorry. Okay, one more. Okay, leave it here. The mobile crisis benefit, which was on the chopping block up until recently. So it's in your director's report, and our chair has referenced their state has allocated some funds from the 988 funding to continue this benefit. There is a lot of work that has to happen for those funds to be accessible by counties, which is why some of that legislation the chair mentioned earlier is coming out, because currently there is no direct mechanism between 988 and county crisis. 988 is a separate service, separate funding pot that has their own staffing throughout the state that is not directly tied to county level crisis services. So the state needs to put all of that together, and also the interface with 911 and OES at the state level has to happen. So the funding is there. How it will get to counties is still to be determined. And for how long this kind of patch will be there is also TBD. So we do know that this is at least for one time for this current fiscal year, and how we will get there, we'll just kind of wait and see. Okay, and so wanted to end on, again, some of the performance measures. We've talked a lot about how in managed care world, just like managed care plans, we have tons and tons of performance measures that we are required to report out on. And we'll talk about it a little bit more as we get into the director's report. But we took 3 selected measures that we wanted to, report out on, and you can kind of see some of the trends looking at timely access, engagement, and peer services. There are dozens of measures that we're required to report out on now as county behavioral health plans. And I'd like to emphasize, and I will emphasize this again in a director's report, this is a reflection of Ventura County and Ventura County Behavioral Health as the behavioral health plan. So this not only includes our directly operated clinics, these numbers also include our entire provider network. So when you see reports coming out, and we'll reference one in a little bit about what's happening with behavioral health plans, what's happening with counties, that includes the entire behavioral health plan system, not just county operated facilities. So with that, these were measures that we're really excited and happy to report on. The timeliness of data within our own clinics and within our provider network is crucial as the state evaluates and kind of slices and dices these measures. And so you will start to see and hear more about reporting for plan performance. It's a huge tenet of Behavioral Health Services Act. Again, there's a lot of threading of Medi-Cal requirements within BHSA. I encourage you to read the BHSA policy guide online. DHCS keeps an active link because it's a living, working document. So that's why we don't print out copies and bring them anymore, because they are literally being changed by the day. And so the most up-to-date requirements and data are available on their dashboards on DHCS's website. And I believe that's the last slide. That's the last one. Okay. Any questions before we move into the director's report? Sylvie?
When you're talking about the data, we used to get the numbers of who is served and which groups. Are you saying that would be in that BHSA report, or because I know we were also waiting on from moving from the last systems to the new systems, and maybe the numbers wouldn't really reflect until we got a good data moving into the new system? I don't know what the systems are called. I apologize.
Yeah, no, it's fine. Great question. I would encourage everyone to just look at the DHCS website, and because you can break it down by county. Whether we bring a report or not, what is on the state's website is what we're being judged on. So you might as well just look and take that. And even if we do have our own internal kind of discrepancies, and we're constantly working with the state to define and, ensure that what we're sending up is being accurately reflected. That's always going to be a thing, because there's always going to be lag, and there's always going to be kind of a little bit of back and forth on how we look at things at the local level versus what they put out on the state level. But to keep it consistent and so that it's not confusing, now that the state has put their public dashboards and they have all the counties where you can compare, that would be the best source of information. And we can send a link out so that folks know where to access these dashboards. And moving forward, that's basically what the state's going to be using across the whole system.
So the reports that we used to get have now moved to the dashboards. And just do you know what the lag time is? Is it a month or two, or?
No, it's kind of annual year. It's like a fiscal year situation. And the state's still trying to determine how frequent they want to update their own dashboards. So it's kind of a work in progress, not just at the local level, but at the state level, which is why I think it's the least confusing to just go with what the state has published, because that's what they're considering their public information.
Okay, and that's what's the fiscal from month to month for, like, when does the fiscal start for?
So it's July. Well, that's the other thing. Some of the things that are reported out are July to June. So like July 1 of 26 to June 30th of 27. But some of the ways DHCS is reporting out now is on calendar year. So that's where it gets a little confusing, because they're actually converting things to calendar year. So you'll have to just see when you look on the website based on what it is you're looking at. They'll even put an asterisk like, this is fiscal year, this is calendar year. It kind of just depends on the measure.
Okay, thank you.
Okay, so if you don't mind, we can just transition right into the director's report. So you have the director's report in your packet. One of the things I wanted to call out, which is very closely tied to this budget presentation, is on page 2 of the director's report related to individual service level reporting, or ISL. This is very much tied to Behavioral Health Services Act requirements, and takes effect on January 1st of 2027. So again, this is a kind of a transition from all of the CalAIM payment reform efforts, the new data collection requirements as part of Behavioral Health Services Act, to start to really pull together all of the services that are provided by county behavioral health, and to begin to try to put dollar amounts to all of these services. These are non-Medi-Cal services, so that the state can use it to inform the development of capitated rates. So what this means is that our service providers, including our county behavioral health clinics, our network providers, we're all going to be required to report out this individual client level information, so the state can start assigning values to them so that they can fully start to cost out the full cost of behavioral health services. We've always kind of joked that county behavioral health and financing is kind of a Frankenstein system, where you're pulling from this funding source and this funding source and this funding source. And again, with BHSA and the integrated plan, having full transparency of all the funding sources at the big level with our integrated plan, this is basically the same thing now at the individual service level, and assigning those dollar amounts so that the state can do what they need to do to assign rates. So any questions on it? It's a heavy, heavy lift. It's going to be a lot for our clinic staff, our provider networks, our administrative staff, our quality teams. It is a requirement. We have absolutely no say and whether or not we have to do it, we have to do it. At the County Behavioral Health Directors Association level, we were successful in advocating that they push it out to January. Originally, this was going to start also on July 1st of this year. And, you know, we said, no one's ready for this. So can you please give us some more time, which was great because the state needed to refine what they were doing and do all that as well. And so we're very happy that we got some more time, but it's in the actual language in SB 326, which is the policy portion of Proposition 1, where it spells out that this kind of information has to be collected. So any questions on that? No. Okay. I did reference the mobile crisis that included the $42 million from the general fund. Again, it will be TBD to see how counties will be able to access that locally. But we're very thankful that the advocacy efforts were there to ensure that we don't lose that funding for a very critical service at this point. And then the last thing I wanted to address is related to all of this and all of the accountability and all the transparency and all of the things related to some information DHCS put out late last week regarding network adequacy and timely access, and counties who are on the list of potential withholds from the state until deficiencies are corrected. This is what I've been talking about all along, as far as the state having to hold counties accountable. And so we have an element on that list. And so are one of those counties working through the deficiency with DHCS. We actually are meeting with them this week to discuss. So I can't get into the specifics just yet because nothing's final. But this is exactly what happens on the managed care side. I will say that the standards are much higher on the county behavioral health side. We have many more measures. And unlike on managed care, where it's typically a pass fail, when you're looking at our specific BHP network adequacy, we're looking at 18 different measures related to network adequacy. And if you miss just one, then you might be on a list. And that's kind of where we are. And again, it's not just county clinics. This includes the entire network. So that's why when I say we function as a plan, that's what I mean. We also function as a plan. So this is BHP as the plan working through this, and we're confident that we will be able to work with DHCS and move forward. And this is really just the beginning of the kind of reporting and how DHCS is gonna put this information out publicly. This isn't anything political. This is just a part of the requirement of moving into a managed care environment. And it's expected that, you know, about 30 counties will experience this at some point during the fiscal year for different measures. So this is not unique to Ventura or any of the other counties that were on the list. This is just the first round. So don't panic. This is just something that's going to be happening moving forward. And if you read the news, you'll see other health systems and other insurance plans are kind of in the news for sometimes when they're inadequate in certain areas and the plan of correction that they have to do moving forward with the state. So just wanted to address that because I know I've gotten some questions from folks, and it's new for county behavioral health. This is the first time it's happening for us. But technically, as a health plan, it's always something that the state was really supposed to be doing as far as holding us accountable and working to ensure that with CMS. And so now that they've kind of gotten their methodology together and we have a better understanding of what it is we're responsible for, and they have the mechanisms on their end to do it, we're kind of in this new phase of managed care and oversight. So, yes.
Yeah, I know you've talked to us about it a lot, but managed care, when it's health, like you break your arm or you get sick, you can get better and you can get a cast and your arm's better and you can check it off the list. It seems to me that behavioral health is a lot more complicated. You have people that are maybe never going to get better. They're, you know, the compliance with medications is far more difficult. I don't know how this is ever going to work. Do you see a world where those 18 things somehow make this work? And because does it deal with those items?
So yes and no. So when we're looking at managed care in this regard, we're talking about kind of the insurance system part, right? Because when you're looking at behavioral health, in that way, it's very similar to other chronic diseases. So you're looking at hypertension, you're looking at diabetes. A lot of folks don't necessarily get cured of that, but they're able to manage it. So that is the expectation, is that as a behavioral health plan, we need to be able to manage people at the appropriate levels. So that may mean for us on the county BHP side, we're responsible for the moderate to severe, right? Especially that moderate group, those people may go back and forth between maybe needing us at the county level of care or maybe stepping down to the mild to moderate through Gold Coast. What we're needing to be responsible for now is to ensure folks are in the appropriate delivery system at the right level of care, at the right insurance level, so that they're in the appropriate network. Because DHCS's focus, which we've seen with CalAIM and especially with Prop 1, is counties, you are responsible for the most severe folks. That is what Prop 1 is, right? Focusing on FSP, focusing on housing the highest need folks. Everybody else, whether they're in the mild to moderate system or the commercial system, you all need to set up your networks to be adequate and responsible so that the counties can focus on the highest need folks. So that is the concept. And so in doing that, it will drastically shift our operations and has. And that's why, again, that kind of prevention focus is not the same as what it was before. The state's saying that's California Department of Public Health. You all do that. County BH, you focus on the moderate to severe on the treatment. And so that's some of the shift there. And so when you start to see on the clinical operations side, that's what we've had to do. Some of our folks who can step down into lower levels of care, whether it be through their insurance, because they have commercial insurance, or through the Gold Coast benefit, through their behavioral health provider. That's where the state's saying you need to put those people in the appropriate delivery system so that you can free up your access so that you can serve the folks at the highest need.
Thank you.
Okay, any other questions? The rest of the director's report is pretty straightforward, but I did want to call out ISL and the update with the mobile prices. If not, that concludes my report.
Thank you, Dr. Dennering, for both the presentation and your report today. As you had mentioned, so much is happening right now. So next up, we'll move into our item on the agenda, which is board member comments and announcements. Might we have any of those?
There were some speakers at the Board of Supervisors meeting, some young men from high school. They're called the Podium Movement. And President of the Board of Supervisors, Gorell, and I and Dr. Johnson, we met with them last week. They have some great ideas. Don't go very well with what Dr. Dennering just said, because they really want to, help high school students as they come in as freshmen so that they don't get stressed out and they don't get anxiety and don't get all those things. But they did have a way of doing it kind of within their own network, not using any. So it was really cool to talk to this group and, hope we can work with them in the schools and figure out a way to do peer-to-peer work that doesn't get into it, but helps kids. They were really well-spoken, both at the meeting and I thought at the supervisors meeting. So just wanted to let you know that. And then I see we're going to get to the data notebook, so I'll save the rest.
Yes, Nancy.
I just want to pass on I ran into Angela Timmons, and I don't know if any of you remember her, but she was the manager of the inpatient unit many years ago, and we were friends, and I happened to see her in a store, and she said they had in there, she's a wonderful singer, and she's retired, but anyway, I said, "Are you still singing?" "Yeah." And so anyhow, she told me about a service that they did at her church for a person who had committed suicide or died in I don't know if it was suicide for sure, but no one was quite sure. But anyway, very traumatic and sad. But she said that the behavioral health department staff helped her prepare a kind of a statement or an understanding of difficult things. And she said it was so well received in her community. And people called her later and said, "Oh my gosh, this is so wonderful." You know, so she wanted me to thank whoever did that. I think it was Loretta. And anyway, it was very well appreciated and important just to know. And, you know, she, of course, gave the credit to the where it was due, but good to know that that was completely outside the realm of job description, just doing the right thing. And so it's wonderful. Thank you.
Thank you. Sylvia?
Yeah, so I wanted to make some corrections on the 988 for veterans. I know I'm not the veteran person on the board, but just having gone through the experience recently, I always miss like one little piece of information that's really helpful. So when you do go to 988, you can press 1, and that's the veteran access line that takes you to the VA, I believe. And that's what was explained to me. Then you get, if you are already in the VA network for mental health, they kind of flag you, so they route you to your provider if you are already with a therapist. And there are like 2 kind of pathways for therapy. One's like for short term, and then the other one's more for long term. And depending how you talk to your provider, is depending which one you're going to go into. So, like for short term would be like just 6 visits, and then long term could be um, long term 12 to 24 visits, depending on what your issue is. And so in my case, I was first referred to short term, and that's what it took like 6 months just to get um, what they call like a initial person to come talk to you. And that's not a therapist. And then that's when I was denied for therapy. And then I had to have my other provider weigh in. And that's when I was able to actually get in. And that's why it took a year. So I know that we were going to talk about like having somebody from the VA come in and talk. I just do remember, I don't know if Dr. Dennering, you remember from last year that um, our November meeting is like the same week of Thanksgiving. And so some folks were even saying, you know, do we have a meeting that week? I'm not sure if we did last year. So I don't know if that's always the best, even though it's like Veteran Month. I don't know if waiting for November is the best month for that. So I don't know if maybe October would be better. So I just wanted to put that out there. The second point is I did receive a flyer from Teresa Comstock about the, I know I brought up about creating a flyer, and Cheryl Heitman had talked about maybe if there was somebody out there that had done one already. So I did get sent one from Napa County Mental Health Board. So I'll send it to the chair and co-chair, how you guys want to proceed with that. If you still want to do a working group like they did. And they did their own logo. So, and this is without their county behavioral health on there. So, and then the third thing is I apologize for coming late, and I'm going to have to apologize for leaving early. So I have to leave around 2:40. So I don't know what that does to a quorum. I was hoping that wouldn't be the case, but we'll be fine. Okay, thank you.
Thank you, Sylvia. Other board member announcements and comments? Okay, we'll move into item number 12, old business, beginning with policy and procedure process update. So worth giving just a little bit of background information on this. And some of it predates some of my participation here. So if there's other information from other members that may add to the conversation, please help. So evidently, last year there was a consideration being given to a group subgroup, an ad hoc group, to develop a policy and procedure for some items that were recommended that we didn't have policy and procedure for. I think some of them related to how it is that we would do recognitions here, how the board would recognize community members and whatnot. And so evidently, as I understand it, that group was formed, although however, there wasn't really an outcome that came from that group of folks. And so we had discussed that in our executive committee about how to address that and what we might want to do moving forward. And so what we would like to do would be that the executive committee can take the responsibility of anything that may arise as needing policy or procedure guidelines to be articulated. We can take on that responsibility on behalf of the group and report that back to you. So we could take whatever your requests and recommendations they might be, do the necessary legwork with that, and then follow up with you on that. That's essentially what it is that we wanted to bring back to you today. So any thoughts on that?
I think it's great. I have some notes on it because I was on that committee, but just in our own defense, we wanted to get the whatever it is they voted on our bylaws done first, and then we were going to fill in. So both Michael Rodriguez and I think, have notes. I'm hoping his are better because mine are gone. So mine will be from memory and his might actually be for real.
Thank you on that, Diane. Yes, we're happy to take the notes to help us get started on whatever may need to be continued. And we're also happy to take whatever you may have now or as they may arise, and reach out please to myself and John, and we can be happy to look at what it is that we may need to have written so that we have clarity around our policies and practices and procedures.
Happy to. I don't have anything with me today. I didn't bring my notebook, but I'll get it to you.
Okay, further conversation on that? If not, then we'll move into our next item, which is site visit ad hoc committee update from John Stencil.
Great, thanks, Chris. So first question, can I continue to be the chair of that committee along with being the first vice chair? That's a question I put out there. Pardon me? Okay, good. Okay, I like doing it, so that's great.
I like you doing.
Okay, so the first thing I would ask is who currently is on the committee, and would we have others that would like to join the committee? I think Chris is on it, and Nancy, is Daniel on it all? Yeah, Daniel's on it. Yeah, so it's the four of us. Anybody else would like to join the committee? I would invite that out first. Sylvia? No?
Not at this time,
Okay.
but I'd be happy to, go to the visits as they come up.
Okay, so I guess the next item I will do is convene the committee again. And we had it rolling pretty well for the last 6 months. So we'll convene. And I think we were doing it on Mondays at 10 o'clock in the morning, not on this Monday. So I would like to convene that either next Monday or the Monday after that. And I'll send out an email to everybody and see if we can get that going. And I am going to make a recommendation that one of the first organizations that I think would be valuable to visit would be Vista Del Mar Hospital, because they have yet another interim CEO that just started 4 weeks ago. Where'd she go? Anyway, it just started. And so I think it'd be important for us to go visit them to see what the status is of the construction, staffing, how the CEO is going to be running it, and meet their team basically, so we can have that really good information and be able to report back to this committee and be able to give some feedback back to the Board of Supervisors as well. So that would be my first recommended site visit.
May I
Yes, Rebecca.
Since I've joined the executive meetings, if it's all right, I'm going to ask to be removed from the committee. Okay? Thank you.
Does that, how many people are now on your committee? Without Rebecca, yeah.
Rebecca, it would be myself and 3.
I'll be an alternate. I have a lot going on, but if you,
Okay. That'd be great. Thank you. And like we did last time, it doesn't mean that only the ad hoc committee can do these site visits. We always open it up to others. And I think it was really good to have other people join some of the site visits last fiscal year, or fiscal year. So yeah, we'll convene this. No? Okay, we'll talk about that as well. Maybe you change it to a different time. That's all I really have as far as the ad hoc committee right now. Yes,
Yes, Nancy.
okay. Great. Thank you.
Okay. Thank you, John. And that is the rest of our old business. We bring to you now next on the agenda, new business. And the first item there is the data notebook. I don't believe it's in print for you. However, it is included in your information packet, I know online. Because it is a bit of a lengthy document. I'm not exactly sure how many pages, maybe 30 or so. But I'll review a bit of the information and background on it, just to give you a sense of what it is and why it's important to us as a BHAB. This, I believe, is the 10th year for the compilation of a data notebook. And I'll read off to you just here some quick remarks in regards to what it is, its purpose, and its goal. The data notebook is a structured format to review information and report on aspects of each county's behavioral health services. A different part of the public behavioral health system is addressed each year because the overall system is large and complex. This system includes both mental health and substance use treatment services designed for individuals across the lifespan. Local behavioral health boards and commissions are required to review performance outcome data for their county and to report their findings to the County Behavioral Health Planning Council, the Planning Council. To provide structure for the report and to make the reporting easier, each year a data notebook is created for local boards to complete and submit to the Planning Council. Discussion questions seek input from local boards and their departments. Planning Council staff utilize responses to create annual reports to inform policymakers and the public. So that's just a brief rundown of what is a data notebook and how we stand in relation to it. As we had received this information from previously over the summer, John and I have discussed it and how to approach it. We've met with Dr. Dennering and have already gotten good input from the department in terms of gaining access to information necessary for completion of the report. It is important for us to note, like it said, that each year there's a specific area of focus. This year's area of focus is going to be students that are under foster care. And so if you are looking online at the template for the data notebook, you'll get a sense of the questions that are part of the actual assessment or part of the survey beginning on page 17. I believe there's seemingly roughly 25 or so. Yeah, 25 questions that require a response that John, I know is and I also will be supporting on getting the information to be able to report back to you as this report is due. The beginning of October, we'll have this information coming back to you at our next meeting. So questions, comments? Sylvia?
Just wanted
Sorry.
to,
Yes, Diane.
it's a heavy lift this year as compared to last year because we had one outside vendor last year that provided our wellness center. So it made it, the year before it was more like this. So I don't know if they give you an easy one and a hard one, but this one, we have several vendors. Some are in our contracts, for foster care. are in our contracts today, which just gives you an idea of how many there are. So just wanted to let you know, but you already know that. You've done some homework as well. I read it and was like, yikes. The other thing is just to make sure that last year, one of our vendors, when I sent them the questions, they went into the survey link and put the answers in. So Loretta's team had to have that undone. So just really hang on to that Survey Monkey link and keep that here, even if you're sending the questions out to someone else, because they think they're being helpful and sending the questions in. It's not at all helpful. So that's my previous experience with the data notebook.
Thank you for that wisdom on guarding the link carefully. Thank you. Sylvia, did you have a question, comment?
Yeah, so I know everyone does it differently. I think one year I wasn't even on the board, but I helped with it as just a public member. And there was different options on how to get the information, whether that was talking over the phone or in person or sending the questions. And that year I did send the questions, and then it was like, oh, well, you should actually talk to them in person. So I would just suggest, like, however is the preferred method, that it's sort of the same, because then you kind of get these different, I wouldn't say different measures, but if you're having somebody talk in person or over the phone or sending the questions, it just kind of gets the information differently. And that's just my suggestion, to have it kind of like cohesive.
Thank you. Appreciating past experience and wisdom on this as we were preparing to embark upon this. My general thought around it was when I seek information that goes into reporting, I typically like to get it somehow in writing, which is very helpful if perhaps I'm writing it down too, but I definitely like to have something I can reference back to make sure that I'm accurate in what I've collected as information. Further thoughts, John?
Yeah. So when Chris and I looked at this, and Cheryl mentioned that usually it's the first vice chair's responsibility to write this. And I looked at Chris and I said, Chris, this is a heavy lifting item, and the time frame is very, very short. We have less than a month to really put this thing together and be able to get feedback back to everybody. So he and I have agreed to work on it collaboratively with other support from the county. Thank you, Chris.
Well, thank you for your input and feedback, and we remain open to your input and feedback through the process so that we can do the best job on it and ultimately bring it back to you all, like John said, in pretty short order. Any further comment or question on the data notebook? Yes, Nancy.
I was reading all the contracts with magnifying glass, but on my computer where I could make it a little bit bigger. But well, I mean, we've talked about how this shift is going on and our focus is on different things. And the majority of the money that we're going to be receiving through the state, I guess, mostly they go for, well, it seems like to me, what we've done in these contracts right now, and that's not the whole picture at all, but a lot of things are funded, and the big dollar amount of funding is for the youth up until 25, 21, different ones, different ages, but it's mostly directed to young people. And I want to remind everybody that a lot of older people have mental health issues and need treatment and we're trying to get in front so that perhaps that list or that falling into, psychosis and that sort of thing will be helped. However, I have concerns, and as much as I have been campaigning for housing for my whole life, but again, at the expense of treatment, that's it just concerns me. And I know that I just want to have us keep our focus on the whole population of people who need help. And I've seen numbers and I've forgotten what they are right now, but in terms of the numbers of people who receive help from behavioral health, the majority are in that middle age thing. It's not adolescents. And that's probably why we're focusing on adolescents, because they need some additional help. Clearly they do. So anyway, I hope it's not at the expense, and I don't know that we have any choice. It's in the law of what it should be spent on, this percentages. And so it concerns me that what's going to happen to the rest of the folks that are already receiving care or will develop many times that first break or whatever realization that somebody has a serious mental illness isn't before 21. So it just makes me nervous and makes me very concerned.
Thank you, Nancy. So we'll move into our next item on the agenda, and I want to apologize. There was, I think, a printing error on the paper copy for the agenda. I believe it's correct, as I recollect seeing it online. So it is posted and whatnot, where we have the next item for new business, item B, which is future presentation requests, and under that is review our previous presentation requests. There have been some of them, and I took note today on one from Sylvia, potentially for the VA to come in October or November and do a presentation. We have a few others on a list of that I'm happy to review or look over with you, but then I want to point you in your agenda to a page right after the director's report that has it's a table, landscape table, where it has BHAB meeting presentations for the year 25-26. And so you see the presentation dates and the topics that were included there. This is a reference for you just to take your mind back to what was done previously so that we're all aware of that. There's also a nice link on there where we can gain that information in case we might have missed that presentation that was done. So with some of these, John and I were discussing and preparing for the upcoming year, planning and presentations. Some of them may be important ones to bring back, but we wanted to get your input in terms of either bringing back or potentially a new kind of presentation. There was a mention of Caltrans and coming to talk about the bridge overpass in Moore Park. There was previously, we have on our list, and want to again seek your feedback on integrated of certified peer services. I noticed peer support specialist services were increasing across the years in your report, Dr. Dennering. There was request for presentation from Gold Coast Health Plan. Wellness centers within the schools was brought up. Dr. Bobrow brought up suggestion for residency directors, the way that I have that noted, but may want to get more information on that, as well as Dr. Bobrow inviting Dr. Cooper to come and provide insight. And then finally, in regards to when we have missing persons too, that was brought up potentially as a topic of presentation. So all of that being said, I want to just pause right here and see what input you might have, highlighting things that are important to the BHAB for the upcoming year and presentations.
Sylvia, I have a question. At the exec meeting, I was inquiring about your suggestion of missing persons. Can you tell us more about that? What is that topic?
Yes, so I was, when my loved one went missing, they'd been missing, they'd gone missing a couple of times. And so I experienced two vastly different experiences with the police. My first experience was resistant to do a missing persons report and doing a be on the lookout. Unfortunately, if you just do a BOLO, be on the lookout, it won't match up if someone is deceased. So they only match up deceased bodies. I'm sorry to be, I don't know what the word is, but not graphic, but it's a sensitive topic. They only match deceased bodies with missing persons. And then the last time that he went missing, it was just a whole different, and I know you can speak more on this, but it was just a different experience where the police were very welcoming on missing persons, and they were saying that they changed their protocol on it and that they really want people to report people with missing persons right away that have mental health disabilities. They also, I know that we've done the blue envelope. They've spoken about that, but there's a lot of people in the community still don't know about that. And then they also have an ID card on top of that. I know the Camarillo Police Department does, or it's what's it called? So it's for children, and then people that there's a name for it. Not sensitive people, but yeah, we'll think about it in a second.
The program's called Kid Print.
Uh-huh.
That's offered through the city of Camarillo, but it also encompasses elderly folk as well, people who are a little older and stuff. It's essentially an ID card. My kid has one. So it's come in and take a picture, you know, some biometrics and a hair sample and a couple different things. I thought I was loud enough. What Sylvia is talking about in regard to missing persons, there is a lot of misconceptions, and like people still to this day think I have to wait this time. I have to wait 24 hours before I call. And I think that a presentation, and I'd be happy to head it up on missing persons and how it applies. Missing persons is governed by the California Penal Code on how we go about missing persons and reporting missing persons and who qualifies. And I could talk on the sheriff's office side, which is very similar to all other agencies in our county, about how to report missing persons, how we investigate that. There's a lot of stuff that the public does not know that behind the scenes that happens when we're looking for missing people, and how we find people and how we close cases. And so that I think is a pretty relevant presentation. The blue envelope program is something different. We can touch on that. Again, if we want, in that presentation, that's not a problem either. That's just probably a 5-minute or a few minute topic on reminding the community about blue envelope, which is available at all public service stations in the county of Ventura for people who suffer from autism, mental illness, et cetera, et cetera. If you have any sort of condition or ailment that needs to be addressed, the blue envelope program is there for you and available at all every single police station in the county. So we can set a date time for a missing persons presentation, and I can either do it myself or I can have the missing persons team come in. They are very knowledgeable about that stuff.
Thank you very much.
Yeah, I also mentioned, I don't know if it's too much, but having the coroner come in too. It's very difficult to have to call them, and whoever answers the phone is throughout the years. I mean, they have to be the most patient and empathetic person probably in the county. It probably has to be the most difficult job, I would think. It's like a unsung hero job to have to answer those phone calls. But we also don't think about having keeping DNA samples. If your loved one has dental records, those are really important too to have, because when they go missing, it's just, you obviously don't think about keeping those things around until it's too late. So there's just a lot around the topic that I think can be very, good for the public. And I know the Candela Group has also conducted like workbooks and stuff to have to kind of create your like missing persons notebook to, with all that information. Because when you're in that stressful time, it's just, your mind is just not there you're not at your best. And that's when you really need to have everything together to help find your family member.
Thanks, Sylvia. Chris, this reminds me of the site visit we did a few months ago down at Todd Road, and it was simply amazing, and I learned so much. And I'm just wondering if this kind of a presentation wouldn't benefit from actually having a panel of 3 or 4 people involved from the coroner's office, the sheriff department, et cetera, and have them do a presentation to try to cover all aspects of what you're talking about, Sylvia.
Well, I'm by no means an expert in every single thing the sheriff's office does, but I know every single person. I have a friend who works everywhere. So when it gets down to it, we can definitely put something together with the medical examiner's office, who I've worked with directly when I worked in major crimes. And I know they're super welcoming and they really want people to know about their operation and the vital work that they do. That does encompass missing people. And so it shouldn't be a problem for us to get together, let's say like at least a 20-minute presentation on how that process works. So let's just set a date and time. We can get it together, and it's not a big ask. It really isn't. We have prepared presentations that we present all the time, and the BHAB and the community would, I think, really enjoy it as a morbid of a topic as it is. But it's definitely worth to get out there to the public.
It may be morbid, but it's essential. And if we don't talk about it and educate the community, then nobody's going to really know about it.
I agree. Don't tell anybody, but I'm also in charge of search and rescue for the sheriff's office. So I do look for missing people on a very regular basis. I'm in charge of the east end of the county. I'm also in charge of the search and rescue volunteer horse team. So there's a lot of aspects to it of people going missing. So
Maybe you can bring Jay also.
that's exactly what I was going to call. So
Okay.
yeah, so not a problem. We'll put something together.
Okay, great. Thank you.
Illuminating, thank you. Further discussion on some of the items that we'd either had previously at 4 presentations or ones mentioned before from the list that I read to you that were provided to us throughout last year. Any other ideas of what you may want to hear about or learn about or as a BHAB? John?
So at the executive meeting over the last 2 meetings, we added maybe 4 or 5 other potential presentations, and one of them came up as a big question. We thought it would be great to have NAMI come and do a presentation, but somebody said, do they exist anymore in Ventura County? And I haven't heard if they do or don't, and I was wondering if we know that for sure. Okay. And then we also talked about VA presentation, Autism Society of Ventura County. It's one of the second best Ventura County or societies. So I thought it'd be good to invite them and have them do a presentation as well. So these are just ideas that we were throwing around. Maybe we could publish that too. Has it? Yeah.
Nancy?
In regard to the Autism Society, certainly it's information that so many of us need. We've heard multiple presentations by family members here at our board meetings that actually, maybe Loretta can help me with this. You get the sense that autism isn't treated by behavioral health. We hear stories about things that happen to those who have these problems, and then the services they received were not sufficient. So maybe you could answer that in a quick way. Yes, they do, or no, they don't. And if they don't, then there's no point in us talking about it.
So the answer, like everything in behavioral health, is it depends. It depends on whether or not they have a co-occurring mental health condition that is covered by specialty behavioral health services. In general, autism spectrum disorder without any co-occurring mental health condition is not covered by county behavioral health in general.
Yes, Andre?
Just a quick look at NAMI Ventura County. Looks like they're active. They have events on their calendar.
Thank you for checking. Okay, any further discussion on presentations for the year? I think we've got a good list of things, and what we'd like to do is begin to put them together in some semblance of an order and start getting people slotted into those, and then bring that back to you with some level of ability to adjust on that too, based upon what we ultimately present to you. So we'll try and get to work on that in the midst of also doing that, and the aforementioned plan, data notebook. So we've got our homework cut out for us. Yes, one more, Nancy.
I noticed in their contracts that Telecare is ending their contract with the Casas out on, do you have other people who are in line to take over, or is that something you can talk about at this time?
Yeah, so I can say that there was an RFP, and so we are working to transition the provider at that location. Correct. Mhm.
I did this wrong each time, I'm sorry. But they are staying on doing Vista and some of those other things that they have been doing before.
So they will remain as a service provider for other levels of care in other areas, but we'll be transitioning out of this program.
And we're now on to, we're on to item number 14, contracts, which is within your printed materials today and the online agenda too. It's several pages long, 6 or 7 pages long, giving you a moment to review and ask questions or provide comments in regards to contracts on this item.
So I will note that there are quite a few, obviously, with the renewals for year end. So we didn't have a meeting in July. So you have all the June agreements, which there were a lot for the renewals for this current fiscal year that began July 1st. And for this current fiscal year. So that's why there's so many, more than usual.
Just had a brief observation about the contracts. It looks like there's a section of or several of them are from 2025 to 26. And then the majority are 26 to 27, as you pointed out, to account for this upcoming fiscal year. What do you know why there's a lot of them that are from last year that are on this document?
Yes. So anytime there there are increases in services from that previous fiscal year, we would have needed to go back to the board to increase for that 25-26 fiscal year to pay out services that were rendered during that time. So this may have 2 different fiscal years. So to, reimburse the services that occurred during the 25-26 year, and then the new contracts that began 26-27 or 26-29. Some of them are multi-year agreements.
Further discussion on contracts? Okay. Then I believe that is going to take us into our adjournment for today. And public comments. Did we not do public comments earlier? We can do them twice. We can, yes. I'm glad that we did. Thank you.
I've been watching you guys play with your mics all this hour. So anyway, hi, I'm Shauna Morris. I'm the president and CEO of Casa Pacifica. And I just want to say thank you, Loretta. It has been such a pleasure to work with you. Casa Pacifica, as you look at your contracts today, we are, Loretta and her team are one of our biggest customers here. And it has been such a pleasure to work with your team. And I see your team here today. So thank you for your leadership. We've had some great times and we've had some really strong and powerful conversations. And I just appreciate your honesty, your forthright, whatever you tell me is going to happen, happens. And so I really appreciate that. And I look forward to seeing where you're going to be next. And hopefully we'll continue to work together. So thank you very much. I will miss you here.
Thank you, Shauna. Further comments, public? If not, then we can come into our adjournment, and I'll invite you all to stay and have cake as we celebrate Dr. Dennering and thank her for her service here at VCBH. Please come and enjoy some cake. Thank you.